Years.
Thank you. Good morning, everybody. My topic is mitomycin C in trabeculectomy. How much and for how long? So I'll start off with this particular slide as to why do we need the use of antimetabolites in glaucoma surgery. One of the reasons why is that we have a number of drugs today in our armamentarium, and these drugs cause a lot of damage to the ocular surface as a whole. So the damage depends upon the type of drug that you're using, the number of drugs you're using, the duration for which you're using the drugs, the presence or the absence of preservatives in them, the cumulative duration if you're using multiple drugs, the frequency of the application of the drops, the combination interaction, and the pH toxicity and the temperature at which the drops are kept. So due to the use of all these drops, something happens onto the ocular surface. So let's discuss what happens to the conjunctiva. What happens to the conjunctiva is something called a pseudopemphigoid or a drug-induced ocular pemphigoid. What happens here is there is a reduction in the number of goblet cells, there is epithelial keratinization, squamous metaplasia, and the list goes on and on. So as a result of this, the ocular surface architecture as well as nature is completely altered, and it gives rise to something which is known as an activated conjunctiva, which is extremely different from a virgin conjunctiva. This leads to the failure of trabeculectomy or the impending failure if you're going to do a surgery in a case with an activated conjunctiva. So we have to use certain things to increase the chance of success. One is the preoperative use of steroids. So if you're using steroids, let's say fluorometholone drops or ketorolac drops for a month or so, studies say you have to use it for a month. Now that's something extremely dicey. If you're using steroids in a glaucoma case for a month preoperatively, the IOP can have huge effects. So the need for antimetabolites like mitomycin C and 5-FU. So there are these studies which were published a few years back as to whether we should use mitomycin C in the trabeculectomies that we are doing. And the answer to that is a definitive yes. So there's no question now that using MMC or 5-FU has become an accepted method to achieve lower IOPs after filtration surgery. Now the problem with using mitomycin C, especially with the mode that we are delivering nowadays, that is with the use of sponges, is we do not actually know what is the actual dose of MMC which is delivered, what is the effect of irrigation, does the dose depend upon the size of the sponge, and in spite of using mitomycin for so long, we still see cases where there is this mitomycin burn and the conjunctiva becomes extremely thin and these thin cystic blebs. So let us take one point after the other and discuss them. First is, what should be the concentration of MMC that you should use and what is the time of exposure? So this is one particular study which was done where what the authors did were that they soaked a sponge in an antimetabolite. The sponge was made of methyl cellulose and they put it on a Wattman's number 2 filter paper and they saw the diffusion of the antimetabolite onto the filter paper. What they found was that after a couple of minutes, at around 2 minutes, it plateaus. That is, there is no more diffusion of the antimetabolite from the sponge onto the surface. So probably 2 minutes is around the optimum time. Whereas the other graph shows you that at each minute, if you keep on changing the sponge, the delivery occurs exponentially. So if you keep on changing the sponge, obviously there'll be more delivery. But if you're using a single sponge, after 2 minutes, the effect plateaus off. So you do not need to keep the sponge for no longer than 2 minutes. Now comes the concentration. So what the authors did in a number of studies was they studied the concentration of the antimetabolite in the conjunctival biopsy specimens as well as in the scleral biopsy specimens. And they found that the optimum balance was reached at around 0.2 milligram per DL or 0.4 milligram per DL, considering the kind of case that you were choosing. And like I mentioned before, you do not need to keep it for longer than 2 minutes. So either the concentration is 0.2 or 0.4, and you can keep it for either 1 or 2 minutes depending upon the number of cases. So that has emerged the norm nowadays. Now, what is the actual concentration of MMC at the sponge site? To study this, there was this beautiful study. This was done on 5FU, not on MMC. However, the results will extrapolate to MMC itself. So what the authors did was, they took biopsies from 3 sites, 1, 2, and 3. They took a conjunctival biopsy, they took a scleral biopsy, and they placed a sponge which was soaked in 5FU at site 2. They used 2 sizes of sponge. One was 7x4, the other was 3.5x2. And what they observed was, if you had a smaller sponge, that's 3.5x2, there was more concentrated delivery of the antimetabolite to the surface of the conjunctiva. So probably using a smaller sponge is not a very good idea. You should have a larger sponge so that the delivery is more diffuse. Similarly, when they studied it for the sclera, they found that the optimum, the maximum concentration was right over where you were placing the sponge. So they advocated that you should apply the sponge away from the limbus to prevent damage to the limbal stem cells. So you should use a larger sponge to prevent MMC burn. You should apply it away from the limbus to prevent damage to the limbal stem cells. Now, there are lots of sponges which are available. So what is the type of sponge that is best suited for your purpose? So there are these sponges, Altomed, polyvinyl alcohol, Wexel, Merocel, and the size of the sponge, like I mentioned, that it should be larger. But how large should it be? So again, I can quote this particular study which was done by Urbaneja et al., where the authors beautifully discussed all these. So what they did was, they took a PVA spear and they cut it 6 mm from the tip. So they made 2 lateral cuts, 6 mm from the tip, and they subcut it into 3 pieces. So for one, they took it 6 mm from the tip. The other, they took it 8 mm from the tip. That means the sizes were slightly larger for the 8 mm group. They also took PVA fluid wick and they cut it into 4 into 4 mm pieces. They took gelatin sponges and they divided it into 2 groups, 3 into 3 and 5 into 5. Dipanjan, can I continue for some time? Yeah. So they cut it into 3 into 3 and 5 into 5. And they observed the amount of MMC which was absorbed by these materials and the amount of MMC which was delivered to the region. What they found was that a PVA sponge or a spear cut 6 mm from the tip, 2 linear cuts subcut into 3 pieces, is the optimum size which causes the exact amount of MMC absorption and delivery. PVA which is cut 8 mm from the tip and gelatin in the size of 5 into 5 mm, they absorbed more and delivered more, whereas a PVA wick and a gelatin sponge cut 3 mm from the tip, they absorbed less and delivered less. So the size of the sponge should be 6 mm from a PVA spear, 2 linear cuts subcut into 3 pieces. Now, effective irrigation, how much should you irrigate it with? Should it be 15 ml, 20 ml, 100 ml or 250 ml? The answer to that can be found in the Moofield's safer surgery system, where the authors state that immediately after sponge removal, you should irrigate it with 20 ml of BSS. So based on all these, a MMC titration protocol was developed. That was long ago, where you gave points to a particular patient. The points depended on the age of the patient, the race of the patient, whether the patient has undergone a cataract surgery previously, whether there was any filtering surgery done previously. And you group them into scores of 0 to 1, 1 to 2, 2 to 3, etc. And then the concentration and time could be titrated according to that. These are charts which are available freely online, so you can search them out. So this was the MMC titration protocol which became very popular a few years back. However, does this titration of MMC really help, or does it influence the outcome? So this particular study by Lee et al. Suggested that while there is some support for a benefit of titrating MMC according to the individual patient variables, there is inadequate evidence at the present time to claim superiority for any MMC protocol with or without titration. So now, what is the take home? What should you do? You should take a PVA sponge, cut it 6 mm from the tip, subcut into 3 pieces. You should use it at a concentration of 0.02% or 0.04%. You can keep it either for 1 minute or 2 minutes depending upon the kind of case, and you should wash it with 20 ml of BSS. However, even after using these safe protocols, you still land up with blebs which look like this. So we still see these blebs because the delivery system as such per se is something which is not properly titrated. So you land up with blebs which look like this and in future can lead to complications. So what's new? The newer trend in antimetabolite use is to inject mitomycin C. So either it's an intratenon or a subtenon injection. So we all prepare mitomycin C. You take the 2 milligrams powder, you add 5 ml to it and it becomes 0.4 milligram per ml. You can withdraw 0.1 ml of this, add 0.1 ml of lignocaine to that. So effectively you're delivering 20 microgram, or you can take 0.1 ml of it, add 0.3 ml if you're more conservative and deliver 10 micrograms. So Dr. Aiki Ahmed and Dr. Khori, they have published studies which are more than 15 years that they are using it safely, and Dr. Dipanjan Pal, me, Dr. Shuchanda Shaw, we have been using it for at least 2 to 3 years, and we find that it's a pretty safe system. Why? Because it gives us the exact amount of antimetabolite delivered to the surgical site. The same dose is delivered every time to every patient, and there is a diffuse area of application. Some authors suggest that if you cannot really see the area of application of MMC, you can use ICG mixed with the mitomycin C. So these are the trends of antimetabolite use. Initially, it was a sponge. Probably now we are going to shift to injection intratenon or subtenon. Thank you.
Thank you, Arijit. I just forgot to introduce you. Arijit works with us. He is our colleague at Desai Hospital as a senior consultant of glaucoma and cataract. And he has done his fellowship from Dr. R.K. sir at the Tirunelveli.
Thank you.
Thank you, Arijit. It was so good.